Pierluigi, the first time I brought my girlfriend Rosa into a professional context was at a barbecue at Michael Clay's house. And I knew the moment I got out of the car, you were getting out of the car in front of us, and we all walked in together. Do you know what happened next?
When we walked into Michael's house, What happened next? No, I don't remember.
The next day, people were asking, why did David leave with Pierluigi's girlfriend?
Well, when you said what happened next, I thought you meant when we walked in the house. Yes. Yeah, I think you mentioned that before, and nobody could believe that, you were with a beautiful Latina woman.
Yeah, but doesn't he steal your girlfriend at every party, Pierluigi?
Well, I got to keep an eye on David because he was wearing a Ferrari T-shirt. So.
Oh, my God. Okay, let's get this show on the road.
Let's do it.
Welcome aboard Lifelines with David and John, your guide to charting the transformative course of crisis intervention and the game-changing 988 Lifeline.
Welcome back to the Lifelines 988 podcast, where every call brings a new beginning. And Pierluigi, we're coming from the heart of Atlanta, Georgia every week, and we're going, usually we say to wherever we're at. Where are you today, Pierluigi?
So today I'm in Aventura, Florida.
Okay. And we're stretching out across the nation. We're diving deep each week into the pulse of crisis intervention. We're exploring the rich history, and we're constantly eyeing the mountaintop of the potential and the promise of 988. We're your host, Dr. John Draper. We call him Brooklyn in this show. And I'm David Covington. We've been doing crisis services since, before you were born, probably. Watch us on YouTube, like and subscribe, or listen to us wherever you get your daily podcast. We're brought to you by Behavioral Health Link. And this episode is going to be really amazing as we have a dear friend, Dr. Pierluigi Mancini, with us today. Pierluigi, you and I have decided we've known each other, well, it's been at least 20 years now.
I think so. When you were still a baby, revolutionizing the world with the technology that was yet to be discovered by millions.
Well, and Pierluigi, you were doing some innovation as well, and I have actually gone into the vault today, so I'm going to surprise you with a couple of things I'm going to pull out. But we want our audience, and John and I want to learn some things. Tell me something about you. Tell John something about you that maybe we don't know, Pierluigi.
Well, my go-to fact is that I've met 5 popes.
Well, we're going to come back to that one. So hold on to that one. That's in our question list. But 2 weeks ago, John Draper, we had Tanja Miles on. She's met 5 presidents. And today we've got 5 popes.
Yeah, that sounds like a wrestling match. Popes versus presidents. I'd love to see that.
The other thing we do, Pierluigi, to start is we, John and I, take a guess at what you're a super fan of. So we both got a blank sheet of paper here, and I'm just going to, John, you got your black marker?
Yeah, hold on. I got it right here.
So let's write down what we think Pierluigi is a super fan of. Now, this is a little harder than your normal one. I don't think it's a sports team. Okay, I got it, John. I'm going to write mine down.
All right.
Okay. Got mine. You got yours?
Yep, I'm ready.
Okay, on the count of 3. 1, 2, 3. I think he's a super fan of adventure.
That's pretty good. What do you think?
And Pierluigi, John says fine cuisine. So did you have something else in mind, or did one of us win today?
Yeah, you're both right. I love both of those. The adventure looks like when I went Superman zip lining in Dubai. It was just like
from
that.
Building to building.
No, it was from mountain to mountain.
Wow.
Yeah, outside of Dubai is the fastest, longest, tallest zip line in the world.
Oh my gosh.
Yeah.
So Pierluigi, I thought you had shared a picture with me, and for your picture for the podcast today, I tried to find it, but I couldn't. But we do have an interactive segment which you'll hold your horses for. But it's going to be, and I looked up at first. The Chat GPT told me that the zip line you did was this amazing one from tower to tower, and I said no, I think it was even bigger than that one. And I said maybe it was outside of Dubai, and it. What was the name of it, Pierluigi?
Al Jail, something to that effect.
Yeah. I think it had like jet in the name or something. You went like almost 100 miles per hour, Pierluigi?
It was 90 miles an hour for 2 minutes.
And were you eating fine cuisine at the time?
Yeah. Well, it's interesting about fine cuisine because the last 3 years, what I love to do has taken me all over the world. So from having steaks in Argentina to having lamb in Egypt and Kuwait, to, of course, having pasta in Rome, and then you can't forget Paris. So, yes, fine cuisine, but actually where the cuisine was born. And then I love to cook. So not as good as my brother Aldo. He's a true chef, but I love to cook.
David, who doesn't want to travel with Pierluigi?
Oh, right. John, what keyed you into fine cuisine?
Just looking at you, I could just see you're a man of fine taste. So
I'm guapo.
Yes, and your food is guapo as well.
Guapo. Look, Pierluigi, I can roll my R's, and I know that guapo means brave or bold, right?
Yeah. Sure.
There's a short difference between guapo and gordo after a few meals, though, right?
Yeah. Very, very close there.
Okay, so Dr. John Draper, we're going to get into this discussion with Pierluigi today, but first, why don't you tell us about our sponsor? And Pierluigi kindly referenced the technology that he saw at Behavioral Health Link back in the early 2000s.
Yeah, he did. It's such a pleasure, David, to have Pierluigi with us today. He's a man who's been championing equity in behavioral health services for decades. And Pierluigi helps us translate cultural programming from the ideal to the real. And as you know, David, translating the ideal to the real is also the aim of the BHL platform that you were talking about, Pierluigi. It's the public health authorities imagine a world where every behavioral health crisis finds immediate practical help, and the BHL platform's groundbreaking software solution does just that by connecting individuals in crisis to the care that they need when they need it. From our innovative call center module to the mobile crisis response module using GPS-enabled tracking to evidence-based follow-up care to tracking real-time bed availability, BHL is transforming crisis response from the ideal to the real. If you want to learn more about how BHL can help your system coordinate crisis care for everyone in behavioral health crisis, just visit behavioralhealthlink.com. David?
Terrific. Thanks so much, John, and to our sponsor. And Pierluigi, you've been doing this amazing work, specifically around linguistic and cultural focus, really looking at immigrant populations. And you've been on our Crisis Jam a few times where we have a trivia question. So we're going to start. And John Draper's been doing really excellent these last few weeks with his really putting the guest in a hard spot. But it's an over-under. So, John, today's over-under is the number of native Spanish speakers in the world. And I referenced my girlfriend Rosa earlier in the program. This is what a typical street in Mexico looks like, with the culture and the rich, warm history. But I'll give you a clue, John, around the number of people that not only do you see the charm of this picture, but for native speakers of English worldwide, we have 379 million people. So if there are 379 million native speakers of English in the world, how many native speakers of Spanish are there, John?
Yeah, I really needed that help, David. And I'm going to still put it over 300 million. I'm going to say 325 million.
Yeah, and John, that's exactly what I would have said had I been in your shoes. Pierluigi, you're going to take the over or the under in
Over.
today's trivia question?
It's way over.
It's way over. So I was stunned, John, and I absolutely, we Americans are very American centric, Pierluigi. We think everybody speaks English. Now, in fact, English is a very widely spoken language, but most people speak it as a second language.
Right. That's primary language is important. Yes.
The reference to Mexico is a hint. I didn't realize that 129 million people live in Mexico alone. But then when you get to Pierluigi's host country, we get to Colombia, Argentina, Spain. They have about 50 million each. Mm-hmm. So we really quickly get to that 300 million. But there are 559 million people spoken widely across Latin America, Spain, and increasingly in the United States.
Yep.
Pierluigi, that didn't surprise you at all.
Not at all. I mean, we have about 50 million in the United States alone. But the 550 million, and that doesn't include Brazil because they speak Portuguese, right? So all these people in Latin America that primary language is Spanish. That was good.
It's not quite twice the amount, but that's a huge number. That was a great over under, David. I love that.
And John, the first time you've been upended by our guest in a few weeks.
Well, it's due because we're talking about the expert in the world in terms of behavioral health and languages. So really appreciate Pierluigi being here today to tell us about that.
Thank you, John.
Pierluigi, in order to sort of get into this story with you, I'd like to start with the very first conversation we had about your potentially joining the Recovery Innovations Board of Directors. And you said to me, I certainly appreciate the focus on lived experience, but I want to know how serious you are about it because you need to understand that I have a history as a convicted felon. So tell a little bit our audience where you were going with that and what that history and how that feeds into your professional journey, Pierluigi.
Well, I think that, anybody that's worth anything that really wants to make change in the world needs to be authentic. They need to be true to themselves. And our life is just how the universe and how your own personal God decides to give you the steps and the path that's going to get you somewhere. So during my 19 to 21, 18 months during college, I developed a very serious addiction, alcohol and cocaine. And like many people who are diagnosed with substance use disorder, a legal issue is what brings us into recovery. And I was one of the blessed ones. I was 21 years old when I was arrested, and the judge, it was a federal court, and the judge saw something in me and understood that my family was understanding of addiction and recovery, and he sent me to a treatment program. And in that program, I was able to find the message and just hang as tight as I could. And I've been in recovery for 39 years, continuous recovery for 39 years. And it was a blessing. So what I come out of this is when I was arrested and I was given the opportunity for treatment, I was still looking at some serious time. But once again, the judge saw fit that I was going to do better continuing my path, whatever that path was, my path of recovery. So I was placed on probation and I was finishing my master's in international business, but fell in love with counseling. So went back to school, got my master's, got my doctorate. And in the year 2000, President Clinton granted me a presidential pardon. And that's what opened up all of these doors for me to be able to find my mission, which is to build that infrastructure for linguistic access for mental health and substance use disorders. But it just keeps taking me to a higher and higher and higher platform because it's now a global issue. So what I started in little Norcross, Georgia, went statewide, went national, and now it's gone global.
And Pierluigi, you could have taken that experience and focused on on people with specifically addictive issues, or even people who've served prison time. Instead, you're really focused on multicultural, multilingual issues, and you've taken that journey. I wonder if you could talk a little bit about how that journey led you to establish SETPA, the organization that you founded.
Excellent. So thank you. I love telling the story. So when I was beginning my recovery, it was clearly evident that my parents, who were bilingual, trilingual, who had lived in different continents, were having these issues with the American therapists. And it was cultural conflicts, explanation of problems, explanation of solutions and treatment planning. So that seed was planted back then, and I didn't know. But once I started working in the treatment field, once I started being exposed to first a private counseling office, then an adult residential program, it started making sense. And in 1997 in Atlanta, I was running another program, a residential program, and some friends came to me and said, "Pierluigi, there's nothing for someone that speaks Spanish, and we're having more and more people who are speaking Spanish who are having substance use problems and even mental health problems." So I'm kind of a type A personality. I saw a need. I went ahead and said, okay, let's open it. So I opened a outpatient substance use program in Spanish, and people started flocking in. And it wasn't anything magical. There were two things that were the key. First, all the programs, the groups were at night. And second, it was free or low charge, right? Because it had to be, when you talk about linguistic access, you're talking about immigrants. You're talking about individuals who are in their journey of learning English. But if anyone that's been to another country where you don't speak the primary language and something bad happens, the first thing we do is, does anyone speak English, right? Because we want to communicate in our native tongue. So it was the same thing. So I opened this agency, people started coming, but nobody wanted to support it. People didn't know what I was doing. They kept asking me for outcome studies. There weren't any. There were only 3 Latino researchers back in '99. So for 2 years, I had all these individuals coming for individual, for group, and it was very overwhelming. I had 2 small children at home, and I got to a point where I couldn't go on. So I sat on my desk one night and I said, God, if I heard you wrong, if I'm not supposed to be doing this, let me know. Because by then I had like 6 degrees. And I said, I know I can find a job. And I went home. It was like 11:30 at night. At 7:30 in the morning the next day, I get to my office, and there are 3 nuns from the Sisters of Mercy with 5 patients and a check for $2,500. I get goosebumps every time I say this. They said, can you help these folks? So since the night before, I said, God, let me know, right? And then this happens the next morning. I just looked up and said, I'll never doubt you again. Because I don't know what
having nuns deliver that check is all more perfect, I don't
know what a bigger message. I'm afraid.
Thank you, God. Yes.
So that kind of sealed it. And after that, I just kept being authentic. I just kept showing up, and then things started opening up. So we got our first grant after 2 years of just myself. We got our first grant from back then, the Fulton County Regional Board, Ms. Pittman and Lynn Copeland, and they had faith in me. They believed in me. There was also another advocate, Ms. Bernadine Brown, and a CARF surveyor, Ricky Brown. So kind of those 4 people guided me and molded me and structured how the clinic needed to be open. We became state licensed for drug abuse treatment, nationally accredited by CARF, with exemplary mention every time. And the place just started growing. It just started flourishing. Everything that we were doing with addiction, I was able to hire my first receptionist. And then I couldn't find bilingual clinicians. And this is kind of where everything started.
Right.
The advocacy for linguistic access started at that point.
And Pierluigi, just talk about the staff you ultimately developed, who were from so many countries of Central and South America speaking Spanish, even Portuguese.
Yes. So what ended up happening, I needed help. I couldn't find bilingual clinicians in Georgia. So I used a business techno visa called the E1B1 visa. And I brought two therapists, one from Peru, one from Argentina. And they were the first clinicians in my agency. But that's a very expensive process. And it's only 3 years, and you can renew for another 3 years. Then you're back at zero.
Mm-hmm.
But what we started doing is I started going to the universities and looking for bilingual students who could go into social sciences or were already in a bachelor's or a master's program for counseling. And I started hiring them from the get-go. And we developed over 40 clinicians that we helped go through licensing. So they became fully licensed bilingual and trilingual clinicians, including 2 psychologists and even 1 psychiatrist did her residency with us because I had a bilingual psychiatrist that could supervise her. So we've developed this bilingual workforce. We can do that at the national level. We really can. All we need is the will. The people in charge need to have the will to do this. Because if I did it with a small nonprofit, just think what the state can do with their budget, right? Right. Then, because my focus was on Hispanic Latino with Spanish, but we also have Brazilians and people and Portuguese, and they speak Portuguese. So they have, we developed Portuguese speaking licensed clinicians as well. And the good news is that even after I stepped down, these clinicians are all over Georgia now, serving many people in Spanish and in Portuguese.
That is wonderful, great. Wonderful, yeah. Pierluigi. So you mentioned good news. We have a segment we're going to move to now that we call the good news. And today we're going to focus on the renewed emphasis on peer supports. And Pierluigi, such a important focus. You're leaning into that a bit, but the state of Georgia has been a pioneer in this area. People like Wendy Tygreen and Larry Fricks and others, as well as the work Recovery Innovations has done here in Arizona and many others here. Medicaid actually released a FAQ just in the last few weeks now. And John, this is a typical reference to including peer supports. What I thought was interesting was its focus on ensuring that they be allowed to provide coverage in emergency room and inpatient settings. And John, your question was about the focus on using peers in crisis care.
Yeah, I think that's interesting. I mean, the idea, of course, is to help people with serious mental health problems in emergency room settings and inpatient settings here. But if we can help them in the community in crisis care as much as possible, they don't have to end up in emergency rooms and inpatient settings. So it's really all of the above, Dave.
Pierluigi, you'll be a speaker at our Crisis Now 3 Summit in Amsterdam in a couple of weeks. And one of the debates we'll have at that event is the use of peers in high-intensity crisis services. Dr. Renee Keat is going to take the position that that role is incompatible with the kinds of occasional intrusive interventions that would occur in those settings. And Arrow Foster from Recovery Innovations will argue that those team members are indispensable to creating the most healing, open, welcoming space possible, despite you having people there who are voluntary, involuntary. Pierluigi, what was your experience with peer supports at SETPA and since?
So I think that peers are extremely underestimated by everybody. And unless you've been in there or you've been present when you see the magic of watching peers work with peers, it's really difficult to say, well, wait a minute, they didn't go to college. No, they did beyond that. They lived it, right? So they've experienced what this person is going to. So here's my thing, though. I know that's good news, but globally, we are doing a disfavor with peers who speak other languages, right? So to me, is the fastest way to get any kind of information, any kind of services to any immigrant community that speaks other languages. It is the fastest way to get it in. We don't have any structure for training those peers who speak other languages in those languages. And they need to be trained in those languages so they know not only the terminology, but they're able to explain to individuals and families the westernized view that we still look at in this country about recovery from substance use disorders and from mental health issues. So we need to develop that. So peers can be lifesavers. Peers can go places where professionals can't. Peers can get people to open up in a way that professionals can't. I'm very proud of this. We had in our adolescent clubhouse, actually the first, because we used to do this before they were called peers. Right. And actually our adolescent was the first, and it was because of what we were doing that the youth certified peer program got developed, because they actually DBH hired her, and then she helped develop this youth peer program based on what we were asking them to do in our adolescent clubhouse. Because especially the youth peers, they could get young people to open up in a way that adults are not able to. So I do believe in peers. I do believe that we have to train them. We have to provide supervision. We have to provide continuing education, because we have to continue to help them develop. And then what I always tell, same thing that I tell interpreters, is like, when you want to stop being a peer, then maybe you can go to school and then become a licensed therapist. And there you go. You can help even more.
Well, Pierluigi, as a peer who speaks the same language as people with behavioral health problems, I think that's an added superpower, because so many people who are primarily non-English speaking don't feel like they're just not understood. And having a mental health problem means they're really not understood. So they really need to feel understood. To have somebody who says, I've been there in their own language, and I experienced what you've experienced, and you can recover, is a crucial role model for people who otherwise feel like, I don't fit here.
Right. So let's put David in the spot, since he put us in the spot before. David, how many people do you think in the United States struggle with not getting any help because of limited English proficiency?
Oh, boy.
Wow. Well, so you gave me a clue, Pierluigi, that you said there are 50 million Spanish-speaking individuals out of the 330 million people we have here now. So it's got to be in that 10 to 25 million range. I'm going to take the high end to be safe. I'm going to go 25 million, Pierluigi.
Yeah, you're right, but the way you got there is not accurate. So we have 49 million foreign-born individuals.
49 million foreign-born, but they're legally immigrated to the United States, but they were born somewhere else, like my girlfriend Rosa and yourself.
Yeah, no immigration problems. 49 million. 25 million of them are still learning English. So that's 25 million people that if
How long does that take on average, Pierluigi?
I'm sorry?
How long does that take on average for someone who's trying to learn English in a new country?
Well, research shows to become fluent is 3 to 7 years. Now, here's the trick. Here's where people get confused. If I go to my mechanic, right, and I actually have a great mechanic, he's from Bosnia, and he can tell me everything that's wrong with the car in English, right? But if I ask Bali to tell me about his emotional health, he doesn't have that language in English.
Right.
He reverts back to his primary language. So it takes 3 to 7 years, because the investment of learning a new language is 3 to 4 hours a day if you want to become fluent, because fluent means to read, write, speak, and comprehend. So there's 4 things to fluency. So we have 25 million people who are not fluent in English, who, if they develop a problem, they don't have anywhere to go, because we don't have that infrastructure. And the same thing we're having with 988, right? So we have Press 2 for Spanish. Now 988 is the culture part. People don't know. Only, Kaiser Family Foundation released a report 2 weeks ago. Only 10% of Hispanics in the United States are aware of 988. 10%. That's not right? We got to do better than that. And it's because of culture, because we still haven't taught this very large growing community how to use 988 and how life-saving 988 can be.
Yeah, and let me just note there, Pierluigi, your success with SETPA was really due to your vocal leadership. There really needs to be a Spanish language speaking leader who is at 988, who's speaking to and with the communities that are being affected and helping to represent the language in their discussions. So they can say, this is a service that is set up for me. A lot of them may not feel like it's set up for them.
Right. And one of the things
back to this topic, Pierluigi.
Okay.
Let's come back to this topic, and I want to go into the issue of beyond language that we talked about. But before we do that, let's do a fun segment, Pierluigi, that we're going to call yes or no. You're all in, Pierluigi, or no way, Jose. That's not something you would do. All right. So, John, Pierluigi has already said he's a just say yes guy. What was the origins of this just say yes thing, Pierluigi?
So, very few people know this, but for 20 years, I was taking care of a loved one, and I said no to a lot. I had to say no to dinners, to invitations, to events, to travel, gave up on the opera and the theater and all the things that I love. So after that period of my life ended, I said, I'm going to say yes to everything. And that's what's taking me to all the places that I've been to in the last 4 years.
Okay, so here we go. We already know he'll do a zip line at 90 miles an hour, John Draper. But for both of you, I'll just mention the amount, the activity, and then you can tell me you do it or no way. You would climb Mount Kilimanjaro in Tanzania. It's a challenging trek. It does take some acculturation to the altitude. It's Africa's highest peak.
I wouldn't climb to the top, but I'd climb it.
I would start it and see where it goes.
Yeah, let's just see what happens.
Okay, that sounds like non-committal. All right, we'll go to the next one. This one you don't get once you start, you're going to do it. Whitewater rafting on the Zambezi River in Zambia and in Zimbabwe. Some of the most intense rapids in the world near Victoria Falls.
Absolutely, yes.
I would say yes to that, too. I love White Rapid stuff.
Okay,
That's
so
cool. But the most intense in the world, I don't know.
I did order these from easiest to scariest. Number 3, volcano boarding in Nicaragua. Race down the slopes of an active volcano on a specially designed board, reaching speeds of 56 miles per hour.
On a board?
What's the survival rate? What's the survival rate of this?
What's that?
What's the survival rate?
It doesn't say. My guess is they, have insurance for this, Pierluigi. You probably have to sign a waiver, but my guess is it's relatively.
What kind of board is this, David? What are we going down on?
It's a specially designed board. You've seen, John, those where there's a chute and you go down. So my guess is this is ramped up by the volcano that you're doing this on, but it's probably not that dangerous.
No, they wouldn't let us in if it was going to blow up on us. So I think I'm going to trust the park guard on that.
All right. So there were some. I didn't get a strong yes. Pierluigi, was that a qualified yes?
Yes. Yes.
Okay. All right. Number 4, heli skiing in Alaska. Take a helicopter to a remote mountain peak and ski down the untouched powder snow for an unparalleled adrenaline rush.
So we jump off the helicopter, right?
Yeah.
Absolutely. Absolutely.
No, I can't ski, so that's just.
So we've reached John's no. Let's see if John's no continues. Number 5, cave diving in the Yucatan Peninsula.
Yes.
So what's cave diving?
You explore the intricate underwater cave systems filled with crystal clear water and unique geological formations.
I've done some of that. I love it.
Do you have to scuba? Or because I don't scuba.
I don't scuba.
It would be scuba diving. Yeah.
I can't scuba. Yeah, I can't.
Well, I can get certified. It takes 3 days in Egypt. I was told that. So get certified and we'll go for it.
Yeah, my son is going to sea camp this summer, Pierluigi, and there's a second week he can't do because you have to be scuba certified. So this coming year he wants to complete that. So maybe you and he go to Egypt together. Number 6, skydiving over Interlaken, Switzerland. Free fall over the stunning Swiss Alps.
Boy.
You've done that, Pierluigi.
Not free fall. I've done the tandem with somebody behind me.
A tandem.
Yeah, I'm not sure.
That's my no.
Yeah.
There's a no.
Yeah.
Number 7, shark cage diving in South Africa.
Yes.
You didn't even hesitate.
It's in my bucket list.
Shark cage diving. So that means the shark is on the outside of the cage, or it's in the cage, and I'm taunting it from the outside.
You're in the cage. You're in.
Yeah. No,
My ex-wife's father actually did this, John. And you're in the cage, and they throw chum in the water, and they try to lure sharks to come. He didn't have sharks the day he did it, but this one's going to be a no, I'm pretty sure. Wingsuit flying in the Swiss Alps. You've seen them when they look like a squirrel?
Yeah.
No.
That's the suit I wore for my Dubai dive. It's one of those suits, but I had a rope.
All right, last one. Do you want bungee jumping or base jumping, John?
Oh, I would. What do you mean base jumping? What is that?
That's you just jump off a cliff and you free fall before deploying a parachute.
I do bungee jumping.
So the bungee jumping is from the Macau Tower in China. You plunge 764 feet from one of the world's highest commercial bungee jumping platforms.
It's okay. I passed out halfway down.
I don't think it matters when you let go. If it's 100 feet or 600 feet, you let go.
As long as the bungee works. But the coming back up on the bungee, I mean, you're probably going to be bouncing up like 8 stories and then coming back down. That's a lot.
So Pierluigi, we see strong evidence that your Just Say Yes is carrying through to some really adrenaline-filled activities. But hey, let's go back to where we were around language and culture. And Karen Jones was, when we were planning this episode, talking about this concept of lost in translation, Pierluigi. And in particular, you referenced a little bit of this as you were talking about the mechanic. But let's go further from language to culture, because it was important to you at SETPA that not only did you have staff who were linguistically connected to the person in crisis or person in need, but you felt that culture was also an important aspect, and that someone from Mexico might not connect in the best way with somebody from Colombia.
Correct. So, culture is just as important as language. In so many ways, it's even more important. So we ended up, before I stepped down, we had staff members from 17 Latin American countries, and we had clients from all 22 Spanish-speaking countries and from Brazil. Now, people would sometimes ask me in disbelief that if we were all Latinos, why did we have cultural responsiveness or cultural competence training? And here's where the thing is. There is a history in Latin America. Like all Latinos, we're a heterogeneous group, but we don't necessarily all love each other. There's competition and there's nationalism and there's all kinds of issues. But then there's also conflicts, and conflict can come from what's misperceived as, wrong attitudes or negative attitudes, or even words that in one country can mean an insult in another country. So we all had to learn about each other as a team, right? So we had individuals from many different countries, and we did. One of our biggest kept secrets is when we had our annual holiday celebration lunch that everybody wanted to come to, is because people brought a dish from their home country. So we had this feast of 22 different countries that people would bring and participate in that. So food is different, music is different, the way we speak is different. There's nuances in our language, the way we explain things, and how that translates to clients, to the individuals that were coming in for help, is their explanation of the problem. So the explanation of the problem from someone from El Salvador who's speaking to a therapist from Argentina, it could be a clash of culture, right? So they're explaining what they think they're feeling, whatever they're feeling, to someone that has never heard that type of explanation. And the same thing, if you had someone from Colombia and you had a therapist from Nicaragua, they can have the same kind of conflict. So culture became very important for us to learn how those countries, the different countries, how they view substance use disorder, how they view mental health issues. There's this whole supernatural belief all over Latin America that has nothing to do with westernized medicine. So there is also a lot of somatic explanations that unless you know this, you think your client really has a back problem. Instead of they're trying to tell you they're in pain, they just don't have the language to do that.
Pierluigi, and thinking about cultural effectiveness and designing culturally effective approaches, I'm thinking about that in terms of this also broad use of the term immigrant. And there's no immigrant cultures, there's cultures within immigrant groups. And you wrote a book, Mental in the Age of Trump, or the Era of Trump, something along those lines, which really chronicled the experiences of recovery for a few persons in the immigrant culture. And this is a very sensitive time, as we know. In fact, it's almost double jeopardy for persons in immigrant cultures now, where they're not only stigmatized and discriminated against because they're immigrants, but also if you have a mental health problem, then you're doubly discriminated against. Mm-hmm. So I'm wondering if we're going to, and you were talking about there's competition between cultures, there's also competition between resources. So if we had to prioritize an immigrant culture right now for us to address, who do you think is at the highest risk from a mental health perspective? And what argument would you make to Congress or SAMHSA as to why we need to prioritize helping this group?
So let me start by clarifying a little bit about the book. That book, unfortunately, was very misunderstood because of the title. So I never say anything negative about Mr. Trump. The book came out when it did, and wanted to highlight that era because immigrants were afraid and they were not seeking help.
Right.
They were afraid to get deported for saying they were suicidal, right? So it was, and I wanted to showcase it's 10 beautiful recovery stories in that book. So I hope people do see the value of watching immigrants recover. They can recover in the United States if we serve them in a cultural and linguistically responsive manner. Now, the question you asked me is really a loaded question, and it's a heartbreaking question because we are receiving children from war-torn Ukraine, right? We are receiving immigrant families, refugees that have gone through such tremendous hardship. When you have a small child tell us that their school was bombed and their homework was lost and they were really proud of that, or they had to leave their toys or their brothers and sisters. So if you were asking who is at the top of the list, I will always put children at the top of the list, because children with severe trauma, if we treat them, if we reach them early enough, we're saving a life of suffering, right? We're saving them from a life of suffering. Now, after children, we do have a very large immigrant community who has adaptation issues, acculturation issues, discrimination, racism. And if you don't have an outlet for that, then those are millions of people that are suffering in silence. So I think that, going back to the peer conversation, if we can begin to develop peers in recovery, there's thousands of people in Atlanta alone who are Spanish speakers who are in recovery from addiction and mental illness, but we don't have a peer manual, a certified peer program. When our beautiful friend was still alive, when Sherry was still alive, she and I were discussing this bilingual training for certified peers who spoke English and Spanish, and that kind of disappeared. We need that. So I would tell SAMHSA, let's do this. Let's develop bilingual trainings. Let's begin with peers so we can invade these communities with information. We can tell these communities in a culturally and responsive manner what 988 is, what symptoms of depression or anxiety, and where you can go for help. And at the same time, when we think about developing workforce, because everybody and their brother has a development workforce focus, but nobody's looking at the workforce that speaks other languages, including deaf and hard of hearing. we have a shortage of clinicians who speak American Sign Language, right? And that has nothing to do with immigration. These are Americans born who don't have access. So I would put those two. Let's develop the curriculums to train and to help bilingual clinicians and peers. And let's work on the workforce. And for the workforce, there are some very specific issues that we can do. Some are legislative, some are procedural. But in Georgia, I know that I've recommended the Department of Behavioral Health to develop an Office of Language and Culture. So there would be someone at the state level that is helping the CSBs and the providers how to think about serving the folks that you're not serving. And the other one is legislative because every state has different rules and policies for licensing clinicians. But we do have licensed clinicians in the United States, but they're licensed, they were trained in other countries, and we won't let them practice as clinicians here. We need to fix that, because that would be a very fast way to start helping all of these people suffering in silence.
Pierluigi, you referenced our dear friend Sherry Jenkins Tucker, who was such an innovator and pioneer in the space of recovery and peer supports. But you also had a personal relationship with First Lady Rosalynn Carter, who was such a champion of this work. Talk a little bit about your interactions with her and her impact.
So, thanks to Tom Borneman, who was the director of the Carter Center Mental Health Program, he would always talk to Mrs. Carter about this issue of immigrants and linguistic access. And Mrs. Carter spoke Spanish, so, not a lot of people knew that. So she understood what the process is to go to another country and have to speak another language, or to learn that country's language so you can go there and speak it. And, like every year, she had 2 major events every year, but every year, at least one of those events, she would invite me to talk about culture, language, any of these issues that were missing for children, for adults, for everyone. And it was, a very beautiful woman, a very beautiful person who was really committed, and she wasn't afraid to use her influence to open doors for others. So I will always be grateful to her for making sure, and that legacy continues, because the director and her grandson Jason, they still want to make sure that these issues get represented, as it was at this last Rosalynn Carter Mental Health Forum, where they asked me to moderate a panel about immigrant children and mental health.
Yeah,
5 popes and Rosalynn Carter. That's amazing.
And you were at the funeral, Pierluigi.
That was also something surreal. It was just a beautiful opportunity, and I called the Carter Center to thank them for the invitation, and they informed me that Mrs. Carter had actually approved the list of the 1,000 people that were going to be there. And I just felt so touched and so honored that my name would be among those.
Well, Pierluigi, this has been a wonderful conversation. Let's shift into our final interactive segment. And, not that I was scouring your Facebook page to check in on my what is Pierluigi a super fan of, but if I had, I would have seen so many pictures that you've posted of yourself giving blood, Pierluigi. Tell us about how far this goes back and your practice of routinely giving blood.
So, to me, giving blood is probably the easiest thing. All you do is give up an hour of your time. And I use the American Red Cross even before they started counting, or there was an app that kept track of things. I would always try and give blood. I encourage my children to give blood. I encourage everyone to give blood. This last time, a couple of weeks ago, I hit the 7-gallon mark of donating blood since they started counting.
Wow.
So,
wow.
My blood type is a blood type that can be used in others, and it's a tremendously rewarding thing. So what I love about it is not only it's something that doesn't cost me anything except a little time, But when my blood is going to be used, which usually is like a week after I give blood, they send me a text and they say, your blood is on its way to the hospital. And then when they use it, they send me another text. And
Come on. That's terrific. So here's what we're going to do. We're going to do a truth or myth about the American Red Cross. And John, you'll join in here. So number one, the American Red Cross core mission focuses exclusively on providing assistance during natural disasters. Truth or myth?
Myth.
Exclusively. That's the word that's throwing me off.
That's the word. Yeah.
Yeah, obviously, Pierluigi just talked about blood donations, health and safety training, international relief efforts. So they do a lot more, although they certainly focus on natural disasters. Number two, the movie about Captain Sully in 2016 featured the American Red Cross following the emergency landing of U.S. Airways Flight 1549. Truth or myth?
I never saw the movie, so to me it's 50-50. I'm going to say truth.
John?
Truth.
Yeah, that was in the movie. The next one, the American Red Cross is a government agency. Truth or myth?
It's a myth.
It's a nonprofit organization. Operates independently, but obviously works closely with the government. Number five, Claire Barton founded the American Red Cross. She earned the nickname the Angel of Verdun during World War I.
True.
Sounds true. Angel Verdun is the name of the character in the Tom Cruise movie, played by what is her name? Emily Blunt. But Claire Barton earned the nickname Angel of the Battlefield for her tireless work tending to wounded soldiers during the American Civil War. So it's a little bit of a trick question there.
You sold it well.
I sold it well. In the past couple of years, there's been a lot of discussion of the impact of war on civilians and prisoners of war. Barton advocated for the U.S. to sign the Geneva Convention.
Oh, true.
I'll say true.
Yeah, it is true. The first version in 1864 focused on the help of the people who are wounded or sick in the armed forces, in the field, established the neutrality of medical personnel. Another movie question. The movie Independence Day in 1996 about an alien invasion showed the American Red Cross providing aid and support to the wounded and assisting in the aftermath of the first attacks.
True.
I didn't see it, but I'll say true.
Yeah, no, that's not true. But the 2001 movie Pearl Harbor did do that. So that was a misdirection there. Let's see, final one here. Volunteers make up more than 90% of the American Red Cross workforce.
True.
They do. They are a critical part, comprising over 90% and playing essential roles in various services. The American Red Cross is responsible for maintaining the National Registry of Organ Donors.
False.
That would make sense to me, but that responsibility lies with the United Network for Organ Sharing. And last one, Norman Rockwell created several paintings featuring the American Red Cross, emphasizing their humanitarian work and the spirit of volunteerism.
True.
Yeah, he sure did. So American Red Cross, Pierluigi, and wow, the interactive text, that's incredible. One of the questions I didn't include is giving blood is painful, but you answered that. For you, it's a very easy process, Pierluigi.
Well, you have to hydrate. You have to be able to hydrate. Otherwise, it's going to be difficult for the blood to flow.
Yeah.
What a great life-saving message. I really appreciate you sharing that with us, Pierluigi.
Yeah. I invite everybody to do it.
Yep.
Okay, so we'll now switch from giving blood to the absolutely true tales of behavioral health link, Pierluigi. And today, John Draper, believe it or not, I'm going to go back to 2005. And at that time, I was given this report by my friend Pierluigi, Latino Mental Health and Substance Abuse Services in the state of Georgia, a report to avoid misdiagnosis, labeling, and misunderstanding. And it talked a lot about the work at SETPA and exactly the kinds of principles that Pierluigi's talked about today. And I began reflecting on that, and at exactly the same time, John, the National Suicide Prevention Lifeline was establishing a subnetwork of crisis centers that could yield Spanish-speaking volunteers or crisis workers for people calling the National Suicide Prevention Lifeline. And so I developed actually I have the proposal right here, Pierluigi, a focus at Behavioral Health Link with a dedicated Spanish language service. We hired a young woman named Claudia Fierro. She worked for Hollywood Mental Health in California. She moved to Georgia, and our focus was on mobile crisis, on training our staff, on data, on demographics, and disaggregating by race and gender, but also language and culture. We actually partnered with you. I didn't remember this part, Pierluigi, but we actually referenced SETPA, Grady Hospital, and Mental Health America in that. And Claudia moved to Atlanta, and we worked together. I believe it was almost a year, Pierluigi, and then she came to me. She said, "I can't do it, David." And I don't know if you remember this conversation, Pierluigi, but she was born in the United States from parents who immigrated from Mexico. And she said it was culture shock that the Latino population in Atlanta that she was interfacing with were predominantly people who were born in other countries and moved. And she said they just didn't jive in the way that she wanted. So you remember this, Pierluigi, and is that these different generational steps in immigration? Is that a thing?
Yes, so that's very much true. So again, it's part of that acculturation and assimilation. And one of the things about Georgia has physical representation of all 22 Latin American countries. So you can find people here from any of them. And if you're born here in the United States, you haven't been exposed to life in Latin America, that's a challenge. Now, on the other side of that, I had 3 wonderful U.S.-born American citizens who were one of our greatest clinicians because they spent 2 or more years in Central America with Peace Corps. So they knew the culture, they knew the language, they became clinicians, so they were able to translate that into their work. And our Latino clients loved them. But, it brings me to this point. I don't know when you're going to shut this down, but here's what I would say to anyone that's listening, a small, large, state, private, government, federal. Health equity and eliminating this disparity of language needs to be a line budget item. It is not an afterthought. It is not trying to get your cousin to come in or Mario over at IT to come and help. No. It has to be a line item budget in order for people to really be successful at this. Otherwise, unless you're in, you're not going to be able to get to where you want to get to or where we need everyone to get to.
Yeah.
It needs to be a line item budget, and there needs to be leadership like your voice. And we need a lot of those voices, Pierluigi.
Thank you. Well, we're getting there. I don't know if you've already seen the news, but last Friday, I was elected chairman of the board for Mental Health America National, and I think that's just going to give me that national platform to continue to have this message out there. So very proud of that. Very proud of that organization.
Pierluigi, we've done this more than a dozen times now, and every time I've ever told an absolutely true tale, John has challenged me whether that actually happened. And this time, he believes it. Only because you're here, I think.
Absolutely. Yeah. I didn't see you in any way give him a skewed look. You seem to actually. Well, you're gonna challenge him after this. I know you didn't want to challenge him on the show, but
yeah, that's right. So, John, Pierluigi, that brings us to our Plain Truth segment. And Pierluigi, you've been speaking truth throughout this podcast, but let's end with a discussion of the Yavas Crisis Center. And I come to you welcoming you to Yavas Crisis Center. If you or someone you know is struggling or in a crisis, help is available. You can call or text 988, and a crisis specialist is ready to assist you. Immediate support is also available by walking in, so long as you come during business hours, Monday through Friday, 8 a.m. to 5 p.m. Please do note that our building is closed for lunch from 12 noon to 1 p.m. Upon arrival, you'll be logged into a queue, and a staff member will see you as soon as they're available to conduct a crisis assessment. You may even qualify for our crisis stabilization program. If you're eligible, we'll guide you through the process, which typically includes additional medical screening at the local hospital emergency room so that we can ensure our program is right for you. Now, at this point, I'd like to insert a big sigh and say, okay, so I made up the Yavis Crisis Center name and this program description, but the rest of those words are nearly verbatim from various crisis program websites in 2024. I resisted the urge to be sarcastic and say it's conveniently located in downtown Stagnaville, but nevertheless, every day in the United States, 40,000 people present at the hospital with mental health, substance use, and or suicidal crisis. And they are there seeking access to care, to crisis stabilization or peer respite, to residential programs, detoxification, inpatient, and they wait more. Some of them eventually survive that gauntlet and make it through to a program, but most give up. In 2013, 10 such individuals sued the state of Washington, arguing that prolonged waits for crisis care in EDs were inhumane. State mental health leaders defended the practice, claiming such cases were outliers and that they were required for crisis programs, inpatient programs, to know whether someone was appropriate. However, a year-long investigation by the Seattle Times revealed that average wait times actually exceeded 3 days, with many patients handcuffed to gurneys and placed in the hallway because there wasn't space or staffing. The state Supreme Court ultimately ruled that such a practice was inhumane, unlawful, and demanded change. In 2019, 64 crisis leaders from around the world gathered in Washington, D.C. for Crisis Now 2 to draft an international declaration for better crisis care. And John, you were there. You shared the concept coming out of your work group that crisis care should be available for anyone, anytime. Within months, the 2020 SAMHSA National Guidelines for Behavioral Health Crisis Care began putting together a document built on that foundation and envisioning a world where behavioral health crises are addressed by dedicated services rather than police and hospitals, except in cases of public safety or medical emergencies. And the Yavis Crisis Centers pushed back, arguing that the guidelines inappropriately dictated specific components for all communities. They believed rather that each community should develop its own unique way of handling these challenges. But this debate echoes the pre-1986 era when hospital emergency departments said the same thing. That's when they selected whom they would and whom they would not treat. They often turned away those unable to pay in a practice that became known as dumping. The term Yavis goes a little bit further, and it was coined to describe the implicit bias in admission decisions when we stand holding the gate. And it looks at how we tend to implicitly allow in more people who are younger, attractive, verbally skilled, in English, Pierluigi, intelligent, and successful. Not to also mention, you saw the people in that Yavis Crisis Center more white, higher socioeconomic, tend to be from sexual orientation and religions that we're comfortable with. Despite initial resistance from hospital providers who said they would not be able to handle the legal liability or the capability to safely operate, Congress nevertheless passed the Emergency Medical Treatment and Labor Act in 1986, or EMTALA. This law established legal obligations for hospitals to provide necessary medical screening and stabilization for all patients, significantly reducing patient dumping and improving access to emergency medical services across the U.S. for everyone. It embodied the concept of anyone, anytime. Whatever you call them, whether they're crisis receiving or emergency behavioral health inpatient or crisis, Every community needs no wrong door crisis facility programs to serve those in need, all those in need. And John and Pierluigi, that's some plain truth.
Anyone, anytime, David, absolutely. So that's it for us today, y'all. Stay cool. Hey, Pierluigi, thank you. Thank you so much for being with us today.
My absolute pleasure, guy. Thank you for
Yeah, just keep on staying cool. Let's all stay anchored and look out for the lifelines that we toss your way next week.